Hi, my name is Behnaz Sarrami. I'm the pharmacist and medical science liaison for IDgenetix. Thanks for joining me today for another 5-minute PGX clinical pearl. Today, I wanted to talk to you guys about the idea of drug-drug interaction phenoconversion. As you know, mental health prescribing is a lot of trial and error processing. So I'm going to use Prozac to be consistent or fluoxetine in my presentation. So when a patient comes in and they're given for depression, they're given, let's say, antidepressant A, which is Prozac or fluoxetine. They're told to come back within 4 to 6 weeks and see how that works out for them. They come back, and there been studied that half of the patients that are on the first time antidepressant, it doesn't really not work for them. So they come in, either change a prescription to another medication or augmented with a different prescription and antidepressant B, and told to come back another 4 to 6 weeks. So that whole process takes some months and months to get patients mentally stable based on clinical judgment of the prescriber, the side effect profile of the medication, and the chronic condition of the patient. So what pharmacogenomics does is combine the science of pharmacology and genomics to personalize a patient's medication for them. So you're cutting back the amount of time it takes a patient to get them mentally stable. So let's talk about a case study of Michael Adams Conroy. He was 9 years old when he got adopted, but he had a lot of mental challenges. So he was put on Prozac, and eventually he was doing better, but his dose was up to 40 milligrams a day. He was doing little better. However, he got a lot of side effects such as hallucination, aggressive behavior. He ended up in hospital, and eventually he passed away. So what happened with Michael Adams Conroy, he had Prozac toxicity. So let's look at Prozac. So if you look at the Prozac right here, fluoxetine, it's metabolized mainly by this enzyme CYP2D6 to S-norfluoxetine, and eventually other CYP enzymes, and it kind of gets degraded down in the body. But it's metabolized by 2D6. And over here, as you can see, it inhibits also its own metabolism. So it kind of goes through a little cycle, if you would. It metabolizes to this S-norfluoxetine, but then inhibits insulin metabolism, and it keeps going. So if you imagine that Michael, who was a 9-year-old boy, he was a poor metabolizer of 2D6. So what was happening, imagine you filling up your bathtub with water but not able to drain it. So he was on this left side building up a lot of the fluoxetine and not able to metabolize it, and also inhibiting its own metabolism, which is why fluoxetine has a long half-life and stays the body longer. So let's go back and talk about metabolism. So when we talk about metabolism, this chart is for more active medications. So a poor metabolism is when the body's trying to get rid of that medication, so it's trying to make it more water soluble. So if you have a poor metabolizer, that patient is getting rid of that medication very slowly, so there's more chance of that medication building up in the body, which is why on the very left-hand side of this chart, you'll see on the bottom, you have one pill. If you look on the further all the way to the right, a rapid metabolizer is a patient that's getting rid of that medication very quickly, where the body doesn't have enough time to absorb the benefits of that medication, which is why you have 3 pills in the middle. But this is for an active medication. So why I say that is some medications are inactive, and by metabolism, they're activated. So here's idea of phenoconversion, which is also called the blind spot of PGX or pharmacogenomics. Here's a case study of a 52-year-old patient that had cancer and had surgery and had pain. So she was put on Tylenol number 3, which you see has codeine and acetaminophen combination. So codeine uses 2D6 to activate, because codeine is an active medication, uses 2D6 to activate to morphine to produce that analgesic effect. So it does use 2D6. So this patient was a normal metabolizer of 2D6, but the patient became a little, let's actually look at codeine conversion just before we move on further. So codeine, again, it utilizes different pathways to get rid of the body, to come out of the body, I guess. But the main pathway is the 2D6. So codeine metabolized by 2D6 to produce morphine, which is the one that causes pain relief. So you need the 2D6 to be working to be able to convert that to morphine. So the patient had depression, was put on fluoxetine or Prozac. And what you see here, we just phenoconverted this normal metabolizer patient to a poor metabolizer. If you see on the far right here, this is the percentage of affinity of like codeine to 2D6 and fluoxetine to 2D6. So the affinity of fluoxetine, obviously, it's higher to 2D6. So fluoxetine is using 2D6 more. So that way, codeine is not able to convert or use 2D6 to convert to morphine. So patient now is not getting any pain relief. So what was added further on to help her with her pain relief was flecainide, which has some analgesic effect. Now we see that we have flecainide that also uses 2D6 to metabolize. So the affinity is a little bit lower for flecainide, but because the dose of flecainide is higher, the flecainide actually wins over fluoxetine. So now we have patient not getting pain relief, not well controlled on her depression, and still on all these medications. So what really had to happen was the patient just be changed to the active form of codeine, which is morphine, and just stay on fluoxetine. Now you see there's no more competitive behavior. So thank you for listening. Tune in next time when we talk about methylation and its relevance to depression.